Hello, everyone. Thank you all for joining the first session of the Cultural Competency Learning Collaborative hosted by the National Center for Health and Public Housing. For those of you that aren't familiar, the National Center for Health and Public Housing is a national training and technical assistance provider. We work directly with housing authorities, health centers, and other stakeholders to increase the access, quality of care, and improve health outcomes and health equity of public housing residents. I should mention that while we are funded by HRSA, the content and the opinions that we are expressing today at this session are our own and do not represent those of HHS. So thank you so much for joining today. I know there's a lot going on and I appreciate your time. I'd like to start with a few housekeeping items. So we would like for this session to be as engaging as possible, and part of that is being able to see your face. So if you do feel comfortable, please feel free to turn your video on, but we are recording, so please mute yourself and only turn your mic back on when you are speaking. And there's going to be plenty of time to do that throughout the presentation and then at the Q&A at the end. Of course, take breaks when you need them, stand up and stretch. We know how difficult it is to be staring at a screen for such a long time. We also have the chat open, and we're hoping that you use it extensively throughout this learning collaborative. So please take the time right now to introduce yourself over the chat, add your name, your organization, why you're here, and something fun like what you're looking forward to this weekend. And while you're listening to the content today, please add your thoughts and your comments as they come to you so that when we get to the Q&A portion, it'll be ready to go. And you'll be able to see comments and questions as they come up. I'll also be asking you questions throughout the chat periodically. So please go ahead and open the chat box. You can make it bigger by clicking on the box on the edge, and so you can see all the discussions as they come in. I really do feel like the chat is the most interesting part of the session and really what sets a learning collaborative apart from a typical webinar. So since this is the first session, the first of 4, we are going to be going over some of the materials and some of the registration items, continuing education items, and then we're going to dive into the content for the day, followed by some discussion. So you should have received a welcome packet by email after you registered with the goals of this learning collaborative, which is to assist health centers in the adoption of the CLAS standards and to help providers treat the diverse patient population. My name is Saki Malik Cho. I'm the Director of Research Policy and Health Promotion at NCHPH, and I'm joined by my colleagues Fide Sandoval, our Research Assistant, and Dr. Jose Leon, our Chief Medical Officer. Together, we're going to be covering the fundamentals of cultural competency, language access, and community partnerships through a combination of case studies and didactic learning, and we're going to be working together to do that over the course of 4 sessions. The welcome packet has some key logistical information like the dates and the times of these sessions. So if you haven't already done so, please block off those times in your calendar. There was also a link in the registration survey in the welcome packet. If you haven't filled that out, please do so. Per HRSA guidelines, we're required to obtain some of that information included in that survey. And then the welcome packet also provides some instructions on Moodle, which is the learning management system we use at NCHPH. So you can access Moodle for recordings, for the slides, for the handouts, the resources, all of that is available there. You are eligible to receive continuing education credits by participating in this learning collaborative. You have to register online and take a pre-test and then take a post-test after each session. The instructions on how to register are in the welcome packet. And if you have any problems with registering or taking those tests, please let us know and we'll help solve that issue. So I'd like to start off this session by asking you a few more introductory questions. So can you please add these to the chat? What does cultural competency mean to you? And what are your current patient demographics look like? And have you seen any change in the demographics in your patient base? And while you guys take a minute to throw that in the chat, I'm going to tell you a little bit about how the demographics and the number of patients served at health centers has definitely changed over the years. In 2019, health centers served approximately 30 million patients, and 24% were best served in a language other than English. And there were 433 health centers that were located in or immediately accessible to public housing, and those served close to 5 million patients in public housing communities. For the 108 public housing primary care grantees, those health centers with the special grants to serve public housing, 35% of PHPC patients were best served in a language other than English. So PHPCs are serving a slightly higher diverse population compared to health centers in general. One way to look at diversity is through the number of patients that speak a language other than English. And then of course, the other is to take a look at the racial and ethnic background. For the roughly 2 million individuals that live in traditional public housing, these are disproportionately from a racial or ethnic minority group. And because these households often grapple with poverty and disability, low education and social supports, many of them are also very vulnerable to health issues. And you can really see a big inequity in the health of public housing residents here. Adults that receive housing assistance have higher rates of chronic health conditions and are greater utilizers of healthcare than the general population. And while you take a minute to look at these statistics, you'll see that not only is there a higher prevalence of disease among those with HUD assistance compared to the general public, but there's also a difference between people living in public housing compared to other low-income renters of the same income group, which really demonstrates the degree and the magnitude that housing and then the neighborhoods that these individuals live in and all of these social determinants of health are affecting the physical and mental health of these individuals, and why it's particularly important to provide culturally competent and sensitive care. So the title of this first session is Fundamentals of Culturally Competent Care. The first two sessions are clinic-based, and the session 3 is more community-focused. And then the last session will be more like office hours, where you'll have the opportunity to have a more open dialogue on the challenges that you face in your own clinical settings, and then identify strategies to mitigate them. If you have any questions about the content we discuss in this session, please enter them into the chat as they come to you, and then we can address those at the end. Every session is divided into 3 modules, and I'm going to provide you with the learning objectives for each module as we move forward. So the first module is an overview of culturally competent care. So the learning objectives are to describe the rationale for developing cultural competence, explain the benefits of developing cultural competence, and then list the 3 themes of the CLAS standards and understand the 14 CLAS standards. CLAS Standards is an acronym by the for the National Standards for Culturally and Appropriate Services in Healthcare. The Office of Minority Health first developed these standards in December of 2000, and they've been updating them periodically. Later in this session, I'll be reviewing the CLAS standards and providing some practical implementation strategies for each one. So we're going to start our discussion by watching a case study. In this case study, you are introduced to Miss Geraldine Williams. She's a 70-year-old Native American female who's been receiving traditional therapy for complications related to diabetes and obesity. She has Medicare and Indian Health Service benefits. So I'm going to pause for a second and ask Fide to please start that video.
Sure. Give me 1 second.
Sorry I'm late. What's on the plate this morning?
Geraldine Williams is waiting in room 3.
Let's see. 6 weeks herbal tea and yoga in the Arizona desert didn't magically make her diabetes go away.
No, but she had a wonderful vacation, and I'm sure she'll tell you all about it.
You'd think losing a leg to diabetes would make someone take their condition a little more seriously. Chart. Good morning, Geraldine. And here we are again. How are you feeling?
I can't complain.
Have you thought any more about what we talked about last time? Look, I'll be blunt and honest with you. We need to admit you to the hospital and make sure we know what's going on with your diabetes. We can get your insulin regulated and work on the right diet and medication for your weight and your heart disease. Geraldine, your diabetes is very serious business. The fact that you've had so many symptoms, dizziness, possible vision impairment, a bladder infection, pain and burning in your remaining foot, and let's not forget your heart disease. These are bad news. The sooner we find out what's going on, the faster we can get you treated properly.
But doctor, I feel so much better since coming back from Arizona. Everybody there said I was
Geraldine, I'm sure you do feel better, but that doesn't change the fact that we still need to act. Diabetes is a very complicated disease that can't be cured by herb tea any more than Tylenol can cure a gunshot wound. They'll make you feel relaxed, but they're not going to treat your diabetes or your weight problem. The people at the hospital are highly trained professionals who know how to deal with this type of thing. All I'm asking is that we do some tests, and then we'll know.
I don't want the hospital. I don't care. I won't go there. My husband went into the hospital when he got sick, and he never came out. They already took my leg. I won't die like that, in some teeny little room that smells of sickness, anonymously. I'm not just another name on a chart. My people in the desert, they taught me how to take care of myself, just like we've been taking care of ourselves since before there was a name for diabetes. And you want to send me off to the hospital to die like an old horse. Well, I won't do it. My family was with me, and I wasn't afraid. I was at peace.
I can't believe it. She really and truly believes that traditional folk medicine would cure her and that the hospital would kill her.
Okay, thank you so much, Fide. I am going to ask our Chief Medical Officer, Dr. Jose Leon, his opinion of how he believed Dr. Brown handled the situation. So, Dr. Leon, how would you have handled this if Miss Williams was your patient? How would you try and communicate with her about her desire not to receive treatment, and how would you try to incorporate her perspectives and beliefs?
Thank you, Dr. Cho, and good afternoon and good morning. Well, good afternoon to everyone, I guess. There are several things that we have to analyze here. First is that in some cultures, the traditional medicine or the folk medicine is ingrained in those in the culture. I can speak regarding the Hispanic population, and the Hispanic population believes a lot on traditional medicine. So we need to have a better understanding of the medications or the alternatives that these patients are using. Second, the process of interviewing a patient, there is something called motivational interviewing that can be used. If a patient is reluctant to receive either treatment or go to a hospital, you need to find through the interview possible ways to motivate the patient and look for a change. So those are the that strategy, in addition to getting additional information on traditional medicine, is the basis for understanding patients from other cultures.
Thank you so much, Dr. Leon. And so not being aware of culturally competent care can definitely reduce the effectiveness of your practice. I want to ask folks on the call today, what are some situations where cultural or language differences can affect the safety or the effectiveness of care? What are the risks to you as a provider if you and your patient aren't able to communicate? And how does effective communication affect compliance with treatment? And while you all are please entering that information into the chat, I'm going to ask Dr. Leon, his thoughts about that as well. Are there any situations where you believe cultural or language differences can impact the safety or the effectiveness of care?
Yes, in fact, there are several issues when you communicate with a patient, specifically regarding medications. Patients need to understand what the medication is for and what the possible side effects of a medication is, or the possible side effects of a medication. In addition to that, there is the other method that we use, which is the teach back method, just to make sure that the patient understands your instruction is just to ask the patient back, so the patient can tell you in his or her own words what the medication is for and the potential of how he needs or she needs to take the medication, and how and the potential side effects of a medication. There are other issues like jargon. There are some medical terminology that we need to try to avoid, because that's going to make the conversation more confusing.
Great, thank you. So taking this all into consideration, can any of you identify some potential benefits of cultural competency? And if you can, please add that to the chat. In addition to what you all are mentioning, providing more culturally competent care can increase patient satisfaction. It can reduce malpractice risks. It can increase administrative and operational efficiency. You can achieve greater compliance with legal requirements, and you can broaden your base. So if you all take the steps to ensure that your patients are understanding instructions in their own words and language, as Dr. Leon mentioned, treatment compliance will increase, and culturally competent care can benefit providers as well as patients. So the CLAS standards were developed to help providers in healthcare settings by increasing the cultural competence of their medical practice. Providers can reduce risk to patients, increase access to care, and reduce disparities in care. I want to pause for a second and ask a polling question. Fide, can you pull up the polling question?
Sure, we will do it right now. And the question is, are you familiar with the CLAS standards?
Fide, I can't see the poll. Can you just let us know what they said?
Sure, so 50% said yes and 50% said no.
Okay, that's great to know. Thank you. So you're going to see that the curriculum is organized in the same framework as the CLAS standards, and we'll learn a little bit more about the CLAS standards and how they can be implemented. The CLAS standards were developed by the Office of Minority Health at the U.S. Department of Health and Human Services to promote culturally and linguistically appropriate healthcare services. You should have a copy of the CLAS standards in your handouts. If they are on here, I'm not sure, but they are definitely on Moodle. So the CLAS standards are fundamental to the core values of achieving equity of care and will help you deliver culturally competent care. There are 3 types of CLAS standards with varying stringency. So the first type is a mandate, which are current requirements for all recipients of federal funds. The second type are guidelines, which are activities that are recommended by OMH for adoption. And then the third type are recommendations, which are just suggestions by OMH for voluntary adoption. So I'm going to go over each of the standards and then some strategies for successfully implementing them. So standards 1 through 3 deal with culturally competent care, and standard 1 is the foundation on which the other CLAS standards are based. It's the overarching comprehensive standard. So standard 1 is patients receive effective, understandable, and respectful health care. Respectful care in this context includes taking into consideration the values, needs, and the preferences of the patient. Understandable care involves assuring that patients fully understand questions, instructions, and explanations from staff. This relates both to populations with limited English proficiency, as well as English-speaking groups with low health literacy. And then effective care results in positive outcomes for patients. So 2 examples of strategies are to focus on behaviors of all staff by providing information in employee orientations, as well as periodic trainings at staff meetings. Another strategy is to show your commitment by adding culturally competency skills into job descriptions and incorporating skills and attitudes into performance reviews. Standard 2, the recruitment, retention, and promotion of diverse staff and leadership emphasizes a good faith effort rather than specific targets. So even though we all see the diversity of our nation increasing, the healthcare industry hasn't yet met the demands of recruiting and retaining bilingual and bicultural health professionals to serve the population. It's important to examine the composition of your staff and see how it mirrors your organization's service area. Staff with different cultural backgrounds can offer ideas that relate to the perceptions and the motivations and the needs of diverse patients. And these staff can help translate health needs into effective messages and services. So having diverse and bilingual staff at all levels is a sign of your organization's cultural and linguistic competence. Standard 3 discusses the importance of cultural competency training for all staff. So standard 3 is all staff receive ongoing education and training in culturally and linguistically appropriate service delivery. Some states require that physicians complete cultural competency training as part of their licensure, and other states are instituting requirements in continuing education programs. So cultural competence education, assessment, and training should be ongoing. Every staff member will encounter individuals whose cultural characteristics differ from their own. And some strategies that you can use to reduce cost is by pooling resources with neighboring organizations, using hands-on experiences as an opportunity to learn from patients, and then publicly recognizing your staff for completing their trainings. The next 3 standards for language access service are based on Title 6 of the Civil Rights Act of '64. Title 6 requires all organizations that receive federal funding to take steps to ensure that persons with limited English proficiency have meaningful access to services. And the Office of Civil Rights has released some guidance to help recipients of federal funds assess their obligation to provide language access services. So OCR recommends that healthcare centers balance 4 factors: the number or proportion of persons with limited English proficiency eligible to be served or likely to be encountered, the frequency with which individuals with limited English proficiency come in contact with the program, the importance or urgency of recipients receiving health services, and then the resources that are available to the recipients and the cost. So these factors will be explained in more depth in session 2. There are many different approaches health centers and providers can use to manage the linguistic needs of their patients. No one approach works for all healthcare settings, and there might be occasions where multiple approaches will be needed. Telephone interpreter services are available sometimes through outside agencies. Another option are language banks, where staff who speak other languages function as interpreters, and those have been around for quite some time. However, those should be used with with a little bit of caution. The best approach is bilingual staff or professional interpreters, then the language banks, and then the telephone interpretation. I'm going to pause for a second and ask Fide if she could unmute the line of Mr. Miguel Mendoza if he's available. Mr. Miguel Mendoza is the manager of the dental clinic at OCE Clinic. And in the registration survey, he mentioned that all of his staff is bilingual. And I would really like to hear from him about his experience in hiring and staffing bilingual individuals to care for his patients.
Good afternoon, all. Again, my name is Miguel. I am the dental service manager at Ole Health. So we have a total of about 10 Spanish speakers within our department. We have currently 4 locations in Napa County and Solano County. So having Spanish speakers have definitely made an impact for our patient care. Having those Spanish speaking staff members are able to empathize with our patient pool. Most of our staff members are either first generation Americans or they have immigrated to the US. They're able to empathize with the struggles that our patients go through. We're able to create community within our actual community. So that has definitely brought in a lot of understanding within our patients and staff members. Patients also feel more comfortable talking to someone that speaks their native language as well. We have noticed that whenever we have a staff member who doesn't speak their native language, there is some reservations from the patient. And even though we do have those translation services, there still isn't that comfortability from the patient to fully understand whatever treatment they're being seen for, whether they have a chief concern or if it's something regarding medication. It is we are lucky in our region to have a vast or large Hispanic community. We are in a agricultural region, so we do get a lot of Spanish speaking families here and they do settle down. So we are lucky within that. But we do also live in a region where we do have a lot of Filipino patients and staff as well. So that has definitely come in handy. So it is definitely a struggle sometimes hiring for those positions that require or would benefit from having a bilingual staff member or a bilingual position. My recommendation would be if you're unable to hire someone that is bilingual, is definitely hire someone that is willing to learn the language within the job. We have a couple of providers who have who their primary language is either Tagalog or Tamil or English, and within the job they're able to pick up certain words, or ask our staff, our Spanish speaking staff, some feedback on their Spanish and able to develop it within there. So that would be my recommendation.
Great. Thank you so much for sharing your experience.
Thank you.
Dr. Leon, do you have any follow-up questions for Miguel?
Thank you, Miguel, for sharing your experience. The question that I have is, have you seen, you mentioned something really interesting, which is some patients feel better when they receive health services from a provider who speaks their own language. The question is the recruitment process. When you have someone who probably is not a clinician, but part of your staff, do you train, or does the health center train the staff on some potential issues on patients' privacy and other issues that can arise from a conversation?
Yes, most definitely. So we do provide training regarding that. We try to be as reserved as we can during those, especially personal or sensitive issues as well. It's a lot of it goes through our HR department, where we're able to develop those trainings or work groups. Yes.
That's great. Great. Thank you. Thank you for your feedback. That's very, very useful for the attendees. Thank you for sharing your feedback and your experience.
Thank you, Dr. Leon.
Thank you. So, so health centers and providers need to learn about and offer tools and resources to their patients, informing them of their right to language access services. Many providers have found that advertising the availability of bilingual services can help increase enrollment from targeted communities. The I Speak card is one tool patients can use to ask for an interpreter and help health center staff immediately recognize the language that's spoken by the patient. The form includes over 30 languages, and patients just mark the associated box with the language that they speak. Handouts of the I Speak cards are available on Moodle in the Session 2 materials. It's Handouts 2.1. If anyone is familiar with the tool and how it's used, please enter your experience there in the chat. I would like to offer a word of caution in using patients' family and friends, especially children, as interpreters, as this practice is really discouraged. There is concern about how well family members or friends can translate medical terminology and whether any other information is misinterpreted or omitted. In fact, some states are trying to pass legislation that prohibits family members from interpreting, and you'll see a case study vignette that demonstrates that issue in theme 2. I'm going to pause for a second and ask Dr. Leon if he has any experiences, good or bad, with using professional interpreters or family members to serve as interpreters.
Yes, Dr. Cho, this is a personal experience. I took, I am a clinician, and I took my mother to to see an oncologist. She was diagnosed with a tumor some years ago, and we had to go to Johns Hopkins University Hospital. And the doctor who was there, and the doctor who my mother was about to see, was from Poland. So she spoke English and Polish, I guess. And when I was there, despite the fact that I am a clinician and I speak Spanish and English, I was not invited to participate. they have their own interpreters and their own people and their own staff to interview my mother. And I really think that that's the best way to do it, because sometimes there are some feelings that can get involved, or some personal or private questions that probably the person, you know, who is getting treatment may not want somebody else to know. So that's the experience that I can share.
Great. Thank you, Dr. Leon. And I see we have something from Anita Rosef in the chat. Fida, can you read that, please?
Sure. So Anita has provided her feedback, and she said, we provide services in multiple ways by and multilingual staff, interpreters, language line. We have scheduled blocks of time for patients with specific language interpreters that are hard to find for refugee communities. We offer increases in pay for staff who become certified for medical translation, and we also offer the training program through our area health education center.
That's great. That's a great tip. Thank you so much for sharing that. So in addition to spoken language, it's also important to ensure that written materials are reinforce the key messages and patients understand the written materials as well. Professionally trained translators must translate written documents, and those materials must be back translated. So back translation is the process where one translator translates a document into a target language, and then a second independent translator translates that document back into English to check that the appropriate meaning has been conveyed. So some examples of administrative and legal documents include waivers of rights, release and discharge forms, and documents establishing eligibility for services. I want to ask folks on the call today if they've had any of these documents translated in their practice and how it was done. So if you could please provide your feedback in the chat, that would be great. The OMH Resource Center can provide some additional tips and tools, and I really hope that you can see the importance of these 4 language access standards, since there are, you know, some hidden costs and risks when language barriers aren't addressed. And those are, you know, dealing with ethical and malpractice issues, taking highly paid bilingual staff away from their job to interpret, and contributing to undesired outcomes such as taking the wrong dosage of medication. Written materials should never be used as a substitute for oral interpreters. However, some signage resources do exist to help limited English proficiency and low literacy patients navigate healthcare settings. One of your handouts for session 2 includes 28 universal healthcare symbols that were developed and tested by a group, and you can find called Hablamos Juntos, and you can find that on Moodle. The next 7 standards focus on the community aspects of the CLAS standards and are practice policies that can foster an environment for culturally competent care in a healthcare in a health center. Cultural competency needs to be fully integrated into the daily life and practices of an organization. It needs to be grounded in an organization's identity, how it recruits staff, how it treats patients, how it conducts business, and it needs to flow from the top to the bottom and from the bottom top to the top of the organization. I would suggest to try and be realistic in the goals that you set and take one step at a time, assigning responsibilities and establishing clear measures of success. And one strategy is to involve community members to ensure that the services and the goals meet the true needs of the community and are authentic. Each healthcare organization should perform a baseline cultural competency needs assessment. This is a self-assessment that should focus on capacity, strengths, and weaknesses of the organization in implementing the CLAS standards. Results should be reviewed and discussed to identify assets, weaknesses, opportunities, and used to develop action plans that might include training and interpreter programs. There is a handout from the Office Environment Assessment Checklist on Moodle. It's handout 3.1. In addition to a self-assessment, you can talk to your patients and the community to learn more about them and how you're doing to meet their cultural competency needs. I want to pause for a second and ask our second polling question. Fide, can you please pull that up?
Sure thing. Okay, and the question is, have you been involved in a cultural competency needs assessment? All right, and the response was 54% said yes and 46% said no.
Great. That's good to hear. Okay, so to meet the needs of your patients, you will first need to collect information that is essential to know in delivering care. Please keep in mind that it's important to distinguish between written and spoken communication. Although a patient may be able to speak English well, without an interpreter, he or she may not be able to read English. So in collecting data on country of origin, you might learn critical information. For example, a patient who is a recent immigrant from Somalia might have very different needs from like a third generation African American. And it's important to recognize that some patients may not be willing to provide this information. Some patients may hear the question and think of it as discriminatory, particularly in our current climate. So it's very important to inform patients and reassure them about the reasons for collecting the information. And then in order to accomplish, you can adapt your intake procedures to include these types of questions and inform patients of the confidentiality and the purpose of the collecting that data. As I mentioned earlier, the health status of public housing residents is influenced not only by genetics and health behaviors, but also by the social determinants of health. Health centers need to understand their communities and their patient populations. Community associations, churches, school districts, local city and county government may have information about the population composition of your area and know more about the perceived needs of the populations. And there's also the census. I want to ask you all to comment if you routinely collect this type of information, these population statistics for your community. Session 3 also contains a data collection resources handout that might be helpful for you to consider if you aren't currently collecting this information, or maybe another example of ways to collect that type of information. Services that are designed and improved according to community needs and desires are more likely to be used by patients and can lead to more acceptable, responsive, efficient, and effective care. Mutual collaboration can help shape the direction and the practice of your organizations, and community feedback can help provide health centers with an opportunity to see themselves as they're seen from the outside and keep doing what's working well and then improve on what isn't. And one strategy is to work with the local housing authority or the public housing manager at the site that's close to you to hold community meetings to get resident feedback. Of course, it's always important to remember that childcare and food increases attendance at those types of meetings. And of course, those kinds of meetings can't necessarily take place right now during the pandemic, but just something to keep in mind in the future. Health centers should not assume that any lack of complaints from patients means that there is no cross-cultural conflict or discrimination that's occurring. Patients might not recognize that they're being treated inappropriately, and they may have fears or cultural beliefs that inhibit complaining, or they may not know that they have the right to complain. So it's important that grievances be handled quickly and fairly, and that patients feel comfortable sharing their complaints with providers at the health center. And we have the added challenge of fear of public charge right now, which makes it even more important to handle complaints in a manner where there is no doubt that there will be any backlash. Finally, informing the public about the steps your organization is taking to implement CLAS is a marketing tool that demonstrates your commitment to the community and can help bridge cultural gaps. We just went over a lot of information about the CLAS standards. I think one important takeaway from this part of the presentation is that each health center is going to be different. There are going to be varying levels of cultural competency, awareness, and skills, and trying to go back and implement all 14 standards at one time is probably unrealistic. Instead, consider implementing one or a few of the standards at a time and then move on to others and build upon your accomplishments. At this time, I want to pause and collect any additional comments or questions you may have as we are going to move on to the next module momentarily. So if you have any questions or comments, please add those in the chat right now. The next module is on cultural competency development, and here are the learning objectives. Please take a moment to review them. It's critical to recognize that cultural competency is not a fixed goal. Many factors affect the attainment of cultural competence, and no one can achieve it overnight. Each of us changes over time based on what occurs in our lives and the other factors that influence our behaviors. I just want to remind you of the case study that you watched about Geraldine while we go over the next few slides. Okay, developing cultural competence helps to ensure effective, understandable, and respectful care for all patients. A goal of cultural competency development should be to balance learning specific cultural facts and information with acquiring effective physician-patient interaction and communication in your encounters. So fact-centered information, it can include culture-specific knowledge, such as an ethnic group's historical context, cultural concepts of illness and disease and health-seeking behaviors and disease patterns. You know, it's not possible for any healthcare provider to know all the cultural beliefs a patient holds. It's more important to seek each patient's understanding of his or her illness and treatment by using attitude and skill-centered communication. Attitude and skill-centered care starts with an examination of one's own beliefs in terms of culture, and also an understanding the different cultures in the community that's served. So again, cultural competency is not a fixed goal that a person can attain within a specific period of time. It's a process and involves a number of concepts. You know, understanding your own beliefs and biases and knowing that what you bring to a clinical encounter, understanding that all encounters are cross-cultural no matter what race or ethnicity or language of the patient you're serving. Understanding that cultural competence is a patient-centered approach and that patients bring with them their own understanding of their illness and their disease, and understanding how you can partner with your patient to negotiate treatments that they are more likely to follow. And there are a number of tools that you and your office staff can use to start their journey to cultural competency, such as cultural competency self-assessments, communication models, and organizational assessments. There are a number of published models and frameworks that illustrate the development and the characteristics of culturally competent care. The model that I'm going to share with you today was developed by Dr. Campina Bacote and describes cultural competence as a volcano. When the desire for cultural competence erupts, it results in a longing to seek cultural competence through genuine cultural encounters. Obtaining cultural knowledge by conducting culturally sensitive assessments and being humble about the process. So the model helps healthcare professionals to see cultural competence as a process that focuses on awareness of your biases and the presence of racism and all of the other isms, skills to conduct a cultural assessment in a sensitive manner, knowledge about different cultures' worldviews and the field of bicultural ecology, encounters including face-to-face interactions and other encounters you have had with people from cultures different from your own, and a desire to be culturally competent. I hope this framework will serve as a tool for examining your own cultural beliefs. So we are now moving on to the final module in theme 1, And I am going to pass this on to Fide. She's going to be handling this module, sorry.
All right, thank you so much, Saki. Are you able to see my screen?
Yes.
Yep, perfect. Okay, so we're now moving on to the final module in theme 1. In this module, we're going to be talking about patient-centered care and effective communication. So one of the questions that we have to start off this topic would be, is anyone familiar with models for effective patient communication? And if so, which models are you familiar with, and have you used them in your practice in the past? And you may submit your answer through the chat as well. So next we have what does patient-centered care involve? So a culturally competent physician must be adept at patient-centered care. Patient-centeredness tends to follow a holistic approach and takes into account the cultural and social influences in a person's life. So promoting patient-centered care can be accomplished when? It can be accomplished by patients receiving information in their own language, when clinicians have an awareness of potential communication difficulties, and when the patient is empowered to be the expert of his or her unique illness experience. So disease versus illness. So I just mentioned empowering patients to be the expert of their illness. And I would like to think about the difference between disease and illness. So it is important for healthcare providers to address a patient's disease and his or her illness. So patient-centered care empowers the patient as an expert of his or her unique illness experience. So let's look back at the case that we recently saw with Dr. Brown and Ms. Williams. So Dr. Brown views Ms. Williams' condition as a disease, right? And he speaks of her diabetes only in terms of physiology and treatment. And we can get your, and he states, we can get your insulin regulated and work on the right meal plan and medication. The fact that you've had so many symptoms, dizziness, possible vision impairment, a bladder infection, a pain and burning in your feet, not to mention your heart disease, is bad news. So these are all things that Dr. Brown was mentioning to Ms. Williams. Then Ms. Williams, on the other hand, has a different experience of her condition. She is not focused on the physiological aspects of her diabetes, but rather on her experience of feeling better after gathering herbs and making tea, eating traditional food, spending time with her family, and praying. She feels peace from handling her illness in her own way and appears to prefer feeling peaceful to receiving treatment. Her past experience of her husband's treatment, as well as her traditional health beliefs, leads her to conclude that entering the hospital will cause her death. So this case also demonstrates the importance of learning about a patient's truth as formed by culture, language, experience, history, alternative sources of care, and power differentials. So physicians have an especially important role in the power differential in healthcare encounters. They hold knowledge, ability, and access permissions through prescriptions and referrals to determine whether a patient receives necessary treatment in a timely manner. So a patient's explanatory model. So effective medical interviewing elicits the patient's explanatory model of his or her sickness. So in a study done by Kleinman in 1981, suggests that asking some of the following questions to elicit health beliefs are explanatory models in clinical encounters. So some of the questions to keep in mind here are, what do you call your problem? What name does it have? What do you think caused your problem? Why do you think it started when it did? What does your sickness do to you? How does it work? How severe is it? Will it have a short or long course? Also, what do you fear most about your disorder? What are the chief problems that your sickness has caused for you? What kind of treatment do you think you should receive? Also, what are the most important results you hope to receive from the treatment? So these are all questions to elicit health beliefs for clinical encounters. So we will now spend the next few minutes reviewing other models that can be used as effective communication tools in cross-cultural encounters. So if you see, we have uploaded a few handouts. And in these handouts, you'll see that we have a list of some models, and we have the Learn model, we have the Bathe model, and we have the Ethnic model. And these are takeaway materials for you and your staff and your office staff. And I will now go over some of these specifics of these models as well. So first, we're going to start with Learn. So the Learn model suggests a framework for listening, explaining, acknowledging, recommending, and negotiating. So we have one question here. And has anyone used the Learn model before? If yes, please describe. And if no, can you think of a patient currently in your care for whom you could apply this model to? And you're more than welcome to submit your response through the chat. So next we have the Bathe model. So the Bathe model provides a useful mnemonic for listening the psychosocial context through asking simple questions about background, affect, trouble handling, and empathy. So background, in regards to background, the simple question is, what is going on in your life? It elicits the context of the patient's visit. Affect basically is asking, how do you feel about what is going on? Or what is your mood? Allows the patient to report and label the current feeling state. Trouble, it deals with what about the situation troubles you the most. It helps the physician and patient focus and may bring out the symbolic significance of the illness or event. Handling, that has to do with how is the patient handling that situation. It gives an assessment of functioning and provides direction for an intervention as well. For empathy, that must be in this case, you would, basically reinstate how difficult the situation must be for your patient. It legitimizes the patient's feelings and provides psychological support as well. So you will see the Bathe model used in a vignette that we will be providing in future videos as well. So lastly, we have the Ethnic model. So the Ethnic model includes questions to elicit information about a patient's explanation of illness, treatment, use of healers, along with negotiation, intervention, and collaboration about treatment. So let's review some of the components of the Ethnic model. Patients' traditional health beliefs, which are based on cultural beliefs and practices and explain illness, should be integrated with evidence-based medicine when possible. So this is one last question that we have. Can you think of a time when this model could have been applied in your practice? All right, and thank you all for your attention and participation in this session. Now I'm going to pass it on to Dr. Leon, and we have finished our first session for today.
Thank you, Fide. We have a few minutes for a Q&A session. So if you would like to ask a question, please use the raise hand icon and your line will be unmuted. Or you can also use the chat box and type your question. While we get some either any questions or through the chat or somebody who would like to ask a question verbally, there is a health center that I would like to mention. This is La Maestra Health Center in San Diego, California. And they provide health care and prevention services to patients coming from over 15 countries. And so they have staff, clinical staff and non-clinical staff providing services, interpretation and translation for some of the materials. They have some legal services, as well as Dr. Shaw mentioned that sometimes patients are going to need this kind of services. And during a discussion with this health center, we discussed when you are looking for an organization that can provide some translation services. You can also go to an embassy from any of the countries. I mean, once you have you have the results of your assessments, then you can go and go to the embassy, call them and ask them for translation services. They do provide translation services if you need help with any of the resources or materials that you would like to provide to your patients. And I'm not sure if there is any question at this moment.
Oh, no questions through the chat. Not yet.
So it's over the hour. So if you have questions for us, please submit your questions via email. You can contact either FIDE or Dr. Shaw, myself, and we will be happy to answer any of the questions that you have. You can go to our website, www.nchph.org, or you can use Moodle and submit your questions through Moodle. So in addition to that, next slide, please. Let us know your thoughts again. I mean, you can either send us an email, go to our website, submit your questions through Moodle, and we will be able, very happy to answer any questions that you may have, either regarding this conversation or any question regarding the materials. Sorry.
No, I just wanted to remind you that there will be an evaluation survey that will be sent to you immediately afterwards. So if you could please fill that out, that'd be great. You are also prepared to, if you're getting the credits, the CMA credits, to go to the online test center and take the test for Theme 1, Fundamentals of Culturally Competent Care, to get those 3 credits. And also just a reminder that the next session will be, Fide, can you go to the last slide? November 10th, next week at 3 o'clock. Thank you so much for everyone for attending. Mr. Miguel Mendoza for his experience at the dental clinic, Dr. Leon for all of your personal experience that you're sharing, and Fide and everyone that has responded on the chat. Thank you so much, and we will meet you again next week.
Thank you, and have a great afternoon.
Thank you. Bye.